with Duty Area 5, the insulin module. It's one of my more favorite because I really get into teaching it kind of things. Um, and there is a little video I show. Is that going to be okay? It's like a song. It's a silly song, but we'll play it. It's kind of how I remember some of what the pancreas does. But we will start out. We're going to be talking about understanding diabetes. We're just going to get down some basic facts of hypoglycemia and hyperglycemia. We're going to talk about managing diabetes. We're going to talk about some glucose monitoring and insulin administration. We're also going to be talking about a little bit more of the mechanics of why we are diabetics, why we have diabetics. This kind of goes, I don't know how well your books go into detail on this, but I kind of get off on a small tangent here because we're going to talk about insulin. Now, does anybody know anything about
Goes hand in hand with people who are diabetic. The pancreas doesn't secrete insulin, so that's why their blood absorbs too much sugar and their blood sugar gets out of whack so easily.
Yeah, that's a good shortened version. It goes a little deeper than that. So insulin is made by our pancreas. Okay, so think of insulin as a key. Okay, so we make keys for every cell in our body with our pancreas. And every cell in our body, we'll say, has a door on it, okay? So we get sugar inside of our blood in order for our cells to use it as, what do you guys think? What would our cells use sugar for? Energy. So we need energy for our cells, right, to feed them. So where the insulin comes into play is if our cells have a door on them, and insulin is the key to opening the door, that would allow the sugar in to the cell to have energy. Now, here's where diabetics come into play. If our pancreas is making the wrong set of keys, it's not going to open the lock on the door because it's made wrong or got the wrong teeth or something's wrong with it, right? So it's not going to open that doorknob. So if it can't open the door, where's the sugar staying? In the bloodstream. The pancreas is making the insulin. So the sugar is going to be in the bloodstream. Now, that causes a specific set of problems. So diabetics, if you guys have ever been around any or you have family members that are diabetic, what it is it stays inside your blood. So it does fairly well in big veins. Have you guys ever saw somebody that's left a sugary drink outside or seen crystallized sugar on a glass or something like that? Okay, so think about that inside of your blood, inside of your veins, in your blood. So it does fairly well in the big veins, okay? So, but when we get up here to our fingertips, our veins actually can't stay that big. We still have to have the same amount of tissue perfusion, which means the same amount of oxygen and blood needs to get there, but our veins can't stay that big. And that happens inside of our feet, our hands, our fingers, our toes, our eyes. All of our smaller organs have what they call macrovessels. They're small. So if you crystallize sugar in a big jar, it just looks like a little bit of roughness around the edges, right? But if you crystallize sugar down inside of a little straw, what's it look like? It would be really clogged, tight squeezed in there. So that's what happens inside of these small vessels. So that's why you get people with diabetic neuropathy. That's why you get people that end up having to have appendages amputated, and people that have vision problems with diabetes. Um, with that being said, um, it causes a lot of issues inside internal organs also because they have those smaller vessels. So, what is the best way to get rid of the sugar that's in the blood? Give it a key to get into the cell. Now, if a diabetic, we're kind of just talking general diabetes right here. So, if a diabetic has sugar in their blood and it can't get into their cells, what would the cell be thinking? What do you think your cells are thinking?
Needs food and energy and sugar, so they're probably hungry.
The cells are hungry. You're exactly right. It is a constant warfare. So you can have a full belly and just eat a extra large pizza, which if you're diabetic, don't. But if you eat an extra large pizza from Pizza Hut or Pizza Town or whatever, um, your cells are still hungry because they can't get that energy that you got from that food inside of them. So your belly is full, you've ate, but your cells are still telling your brain, whoa, I still need sugar, I need energy, I need food. So there's where the battle starts, and there's where we get non compliant diabetics. That is a huge thing. So when the cells are telling the brain I'm hungry, then they're just going to eat more sugar, right? And that's why you hear diabetics say, I just crave sugar. I can't help it. I love candy. Well, it's not that they're actually saying, I'm just a candy junkie. Their cells are saying, I'm hungry. I need sugar. So it's a constant battle between the body and the brain and then the disease process. So it's very vicious, actually, if you think about it. They're fighting their own self. So the technical name is diabetes mellitus. You have something else that you'll hear sometimes people might say, if you're in the medical field, you might hear somebody say, I've got diabetes insipidus. Well, that's a whole different thing. That deals with the kidneys and stuff. But diabetes, as we know it, we just say, oh, I have diabetes. The technical name is diabetes mellitus. So there's a type 1 and a type 2. So we kind of talked about energy in the body, right? So we need gas to fuel our car to make us run by eating food. The key to getting the fuel into the cell is insulin. So in order to lubricate this process, we're going to have to go by a food pyramid that's altered for a diabetic. So they kind of use an analogy here of a car needing oil and gas to function. So we need these things to function inside of our body to get fuel to us. So this is a regular food pyramid. The big bright orange over here is a regular food pyramid for me and you and whoever is not diabetic. So this is grains. You see all the starches and stuff here? There's also going to be vegetables, fruits, milk, meat, and beans. And they all look, pretty evened out except that little yellow stripe there. Um, this is an altered food pyramid, which they don't use the food pyramid anymore much. They use the plate idea for portion size and things of that nature. But food pyramids still exist and we still talk about them. But you see a lot more common if you go to a place where you work at in a kitchen, they'll be saying, oh, we're going to use the plate and show you how much portions of starches and fruits and vegetables, and it's actually a little picture of a plate. So a little bit different, but these are some older slides. But um, the thing of it is down here, you're going to have whole grains at the bottom, and then you're going to have plant oils over here, fruits, vegetables, and then nuts. Um, nuts, and then like the legumes, which is the lima beans and stuff. And then dairy and calcium. Then red meat up here at the top, and then this up here is the starches, the wheat, rice, white bread, potatoes, pasta, sweet, spaghetti, that little piece. Now that looks a whole lot different than over here. So with a diabetic, it has to be changed to more protein instead of more starches. So they need more proteins than starches if they have hyperglycemia. Now, the symptoms of diabetes is frequent urination, excessive thirst, extreme hunger, unusual weight loss, increased fatigue, irritability, and blurry vision. He talked about insulin and glucagon coming from the islets of Langerhans, and that's where it's coming from. So, um, and then he said life is like a lazy tryptophan. That's actually a hormone that it is secreting for us too. So it's got a lot of stuff in it. And if you're ever thinking about expanding your background in medical or anything like that, it's kind of a neat song to kind of just teach you a little bit about what's going on inside the pancreas that you got in there. But so we have two types of diabetics, and our pancreas has a lot to do with which one we are. So type 1, that's the people we see taking insulin shots daily. And you will be getting those people. It most often affects children and young adults. It occurs when a person's body does not make its own insulin. Type 2 occurs when the pancreas doesn't make enough insulin. So it's letting in a little bit of, it's throwing a little bit of keys out there for our cells to open doors. Or the body isn't able to use the insulin it does make. So it's making keys with the wrong teeth. So our body can't use it. Our doors can't be opened with that. So the type 2 diabetes can affect people at any age. And 80% of those people with type 2 diabetes are overweight. So both types have similar effects on the body and are often treated in similar ways through regular blood sugar testing, careful food choices, frequent exercise, and insulin or other medication. Now, when it says careful food choices, it's not saying go on a diet, it's saying adjust that food pyramid. Because again, like I said, our body is at warfare. Our cells are saying, I'm hungry. Our body is saying, I'm full. Our brain is saying, feed me more. So it is a vicious cycle, and these people really struggle with this stuff. So let's go on the other end of the spectrum and talk about low blood sugar, hypo. So if you think about it, if someone says, I'm a hypoglycemia, you think, well, that's high blood sugar. To keep it from getting confused, you could think hyper is always up, so that's high blood sugar, and hypo is low blood sugar, so hypo. So hypoglycemia occurs when blood sugar drops too low, generally 70 milligrams or lower, causing the client to feel weak, shaky, irritable, or confused. Now, those symptoms sound pretty similar to the other, and it's hard to tell sometimes. So we definitely never want to treat a patient without knowing. So if a patient was to become, if we know they're diabetic, even if we know they have hyperglycemia, but if they just took insulin and then they, they faint in the floor, we're not going to want to treat until we get a blood sugar test. Because, yes, too high could cause them to have gone into a coma type state, but too low would cause them to be confused, irritable, and could cause them to faint. So you never want to treat until you know. At that point, you still want to call 911 because either way, it's a really high spectrum of either way. No. Um, so you're going to want to talk to the healthcare provider about what blood sugar level constitutes hypoglycemia for the client. The key is to identify the symptoms early and treat it before it gets worse. Now, I will say this, my wife has hypoglycemia, and the best way that we can tell when she's getting low on sugar, she can just eat supper, and then her pancreas makes probably insulin with the wrong keys. Or maybe it's making too many keys. It's probably making too many keys. So she's ate, feel full in her stomach, but her cells are still not full. And then she gets very shaky, weak, sweaty. And I have found her, we'll eat lunch and then go do some yard work or something, or I'll go to get gas for the lawnmower and she'll be there. And I have came back and found her in the yard, passed out from low blood sugar. So it happens to people. And the best thing to do is to know and teach your patients to know the keys when they feel like they're getting sick, to take in some definite sugars. Now, you think, well, how am I going to know what's what? We're going to go over that, how you would treat it, how you would teach your patients to treat the hypoglycemia. So some other symptoms of hypoglycemia is going to be sweatiness, irritability, blurred vision. They may see some spots, but they're probably getting close to fainting at that point. Nausea, shakiness, passing out, fainting, cold, clammy skin, confusion, nervousness, weakness, rapid heartbeat, and they can get a numb lips and tongue. Now, to treat it, I said we want to talk about that. We're going to talk about the 15 to 15 diet. So we're going to do 15 grams of carbohydrates every 15 minutes. And then test the blood sugar again. And if it's still low, eat 15 more grams of carbohydrates, then wait 15 minutes and try again. And if those results are still low, you want to notify a healthcare provider because something is going wrong that we aren't going to be able to treat in a setting with no physician or at a home setting or something like that. This is good information for your family members too if you know anybody with hypoglycemia. So we're going to do that 15-15 with caution though, because if you overtreat hypoglycemia, what are they then going to become? They're going to become hyperglycemic. So, we could go from the depths of the jungle into the depths of the forest. Either way, we're still going to be lost. So, be careful not to overtreat that hypoglycemia, the low blood sugar. It could go too high. So, let's talk about what 15-gram options look like. Nobody really knows what 15 grams of sugar looks like, especially when your loved one is sick or something there. Or if your client is sick and you're nervous, you don't know what to do. So here are some small options that resemble the 15 grams options of sugars. So 4 ounces of fruit juice, 6 ounces of regular soft drinks, not a diet soft drink, not the no sugar, the nice healthy stuff that we see everywhere now that they want us to drink. We want the regular tough stuff. 1 tablespoon of honey, 3 to 4 teaspoons of just regular granulated sugar. So if it's here and nobody has nothing else, we know we have usually sugar packets in the kitchen. So we could get 3 to 4 sugar packets because there's about a teaspoonful in each packet. 2 tablespoons of raisins or 8 hard candies. So if anything, I know at the front reception, there's usually some hard candies there. 8 hard candies. Tell the client to always carry one of these foods because low blood sugar can happen quickly. So the client should be prepared to act quickly to correct it. Um, and it does happen very fast.
Do we have any of those tablets or the exact amount of forms?
We do not. We need to get some ordered, but yeah, we don't have any. We could pick those up from Walmart pretty easy, but we need to get some just for and in a case like that. But untreated low blood sugar can cause serious health problems. A person with untreated hypoglycemia, which is low blood sugar, might cause a person to faint or lose consciousness or experience seizures, and it can progress to death. So, people who are unconscious or unable to eat should be given an immediate injection of glucagon. Should you give that? No. For one, it is prescription. For two, it's an injection. And for three, it quickly raises blood sugar, so it can be dangerous. Usually, I've not ever seen anybody bring glucagon in with them. Now if they did, we would delve into a little bit more of what would happen if something like that happened. But if that happens, most of the time call 911 because we don't have glucagon here because it is a prescription. They usually have it in ERs and they have it in ambulances. Now, if a client has a severe reaction and has no glucagon, call 911. We just said that. So immediate help is very important to anyone who is having seizures or who has passed out. And clients should wear a medical ID tag on their like a bracelet or a necklace stating they're hypoglycemic. Now, hyperglycemia is caused by too much food or the wrong foods, too little or no exercise, too little diabetes medication, or not taking diabetes medication as instructed. Now, too much stress, infection, or illness. Now, when I say too much stress, what do you all think I mean by that?
Maybe like highly acute stress, like something extreme that's happening maybe, or
Yeah, highly acute stress, mental stress, and then physical stress can cause it too. Um, we get these nerve responses, parasympathetic nerve responses, when we're in a stressful situation. So, what happens when you're in your car and you're driving down the road, and all of a sudden, boop, you see blue lights behind you? What happens? Blood pressure goes up, heart rate goes up, you know, all of a sudden you're not thirsty anymore. Uh, you don't have to go to the bathroom like you did. You know, you're like, oh my gosh, I'm getting pulled over. Everything kind of seizes and you're like, woo, you know, you're on high alert. At that point, your body is then delivering more fuel to the cells because it thinks there's an emergency situation. So that is what I mean by stress. So something like that could cause you to be hyperglycemic because you get a fight or flight response inside of your body. You're going to stay and fight or you're going to flight. Either way, we got to have energy in those cells to do it. At that point, then your digestive system slows way down. You don't have to go to the bathroom like you did or anything like that. Your urinary system slows down. Everything does until you get back to the rest and digest. So that means that your body is then you're like after the cup pulls out and you pull out and you drive for like 15 more minutes and you're like, you kind of take that breath. All of a sudden your stomach starts rolling. You got to go to the bathroom again. You're like, your body's starting to reacclimate back to itself. So, and then also I could be physical stress. You broke a leg. You hit your hand with a hammer and broke your three fingers on this hand. That is going to cause your blood sugar to go up because it is physical stress and it's an injury. Signs of hyperglycemia. So these are fatigue, increased appetite, increased thirst, frequent urination, blurred vision, dry, itchy skin, poor healing of wounds, or flu-like aches or headaches. One or more of these signs may indicate high blood sugar. Now, these signs can sound kind of similar, don't they? So hypo is sweatiness, irritability, blurred vision, nausea, shakiness, passing out, fainting, cold, clammy skin, confusion, nervousness, weakness, rapid heartbeat, numb lips and tongue. So, and then for hyperglycemia, it's fatigue, increased appetite, increased thirst, frequent urination, blurred vision, the dry, itchy skin, poor healing of wounds, flu-like aches and headaches. Those sound so similar, don't they? So, preventing hyperglycemia. To prevent high blood sugar, we are going to take diabetes medications as instructed, follow meal plans and follow exercise plans, and decrease the stress. Put you on some smooth jazz and a aroma vaporizer thing and decrease your stress. Um, you're going to take care of an illness or infection quickly. So if you're sick, your body needs more energy to help fight off the sickness. So it's going to increase sugar output. And then testing blood glucose often. Those are going to be some things that help treat hyperglycemia. Okay. Now we're going to talk about blood glucose testing. Now, I do not have a blood glucose tester for this class. I wish I did. The only blood glucose tester I have is downstairs, and it's for if patients forget theirs at home so they can get another one. I'm pretty sure they wouldn't appreciate me using it for the class. So we're going to talk about it. Have you all tested blood sugar before on someone? Have not.
Done the thing where you prick somebody's finger.
Yep.
I've done it to my dad.
Yeah. When you prick the finger, that's what I'm talking about. You have done that? Tracy, have you ever pricked someone's finger and got blood sugar? Okay. So we're going to talk about what it means, what is normal and abnormal readings, and what to do for abnormal results and how to do the test and document it. Now, insulin administration. There are different types of insulin. There's intermediate acting, short acting, and long acting. So you may see a guy take a long acting insulin twice a day, like morning and night, and then take a short acting insulin in between each meal. So before he eats his meal, he might check his blood sugar, take some insulin 3 times a day. So he'll actually be taking, 4 shots a day, 4 to 5 shots a day to keep his blood sugar under control. Especially a type 1 guy. So, and then the route of administration, there's subcutaneous. It injects in the fatty tissue. And then I will give you a handout with some approved sites. Most of the sites, the ones that we would probably use, are going to be on the stomach right here or on the back of the arms right here. They can give them right here. They can give them at the lower end of the buttock the hip area. There's different areas that you can do it. So, and I'll give you a handout with those on. Yeah, yeah, there's injection sites in your book. So, there's different types of insulin. Now, insulin is derived from beef and pork. Um, so most people don't ever think about that, but where do we get insulin from if we don't make it? And animals make insulin too. So the safest type is going to be beef and pork because we can consume beef and pork and we're okay. So um, there's beef and pork, and then there's a mixture, and then there's Humulin R that's regular, and it's a marinate thing. Um, Short acting, intermediate, and long acting, we talked about that. And they usually check their blood sugar before breakfast, lunch, and dinner, and at bedtime. And you're always going to check your blood sugar first before you give any type of insulin. So you may see on the MAR, it may say FS, QID, 4 times a day, or it may say FSAC and HS. That would be before meals and at bedtime. So you may see that. And then now the MAR it looks a little confusing because the fact you're going to have those times all lined out. It looks like a lot of information. And it is because we got to record every time that they check the sugar, we got to record it. And that's to ensure safety of the patient and liability for us, and then safety of us helping them administer insulin. Now, most of our guys will administer their own insulin. We just have to be able to monitor exactly what they're getting out. Now, that being said, they also do their own finger sticks lots of times. The best thing to do is to educate them on the proper way to do it. Now, I'm just going to be up front and I will tell you some of the horror stories I've seen is I will hand them some alcohol pads to clean their hands or clean their finger off, and they will lick their finger, stick it with the lancet, get their blood onto the blood glue, and then lick the blood off their finger. Now that's just real life. That's how they do it. That is not the correct way at all. And the best thing to do is educate. When you are doing these things, education is going to be a huge thing, because we're educating them to say, hey, you need to be checking your blood sugar. Hey, this is the correct way to do it. Hey, you need to adhere to your medication regimen. Hey, you need a doctor to talk to about your medicine. Let me help you and show you how to make an appointment. Or, we're going to be doing a lot of education. And that is a good thing because people who have either been in substance abuse for a long time or had really bad relationships or have mental health issues may have never really got to learn the correct way to perform those life skills. So education is a big thing, and I know Tracy's done a lot of that in her line of work for a long time, so she can probably vouch that education is a huge part of what we do. Um, so
Yeah, I was just gonna say, yeah, it's huge.
it's very huge, lots and lots of education. Down from medicine to making an appointment to getting in touch with lawyers and everything. So it's huge. Education is huge. Um, these are insulins, different types, and then their action times. Basically, it's just showing you the difference of how long that long acting and short acting and intermediate acting works. So, and it kind of shows how it plateaus out just with the little bar graph. Something happened to my slideshow here. Okay, so do you guys have any questions about insulin? Don't think so?
So. Are we allowed to give this one?
You are going to be allowed to give insulin. Most of our patients will do their own. So before we go and we hang up the cameras and all that, I've just got one parting statement, and then we'll turn off the cameras and everything, and we'll continue on with the testing portion. I need to do this before I do the parting statement. This is going to be just a quick example of how we're going to do an insulin shot, okay? Okay, so this is going to be our patient. This little red box is our patient. What it is it's made of, it's got like a rubberized top on it to mimic skin. And then it's got cotton or an absorbent layer inside. And this is just a housing around it. So it gives us the reality of kind of giving an injection or a shot. It was donated to here by Lilly Diabetes Company, and they were really nice to donate us some stuff to teach this class with. So they do lots of diabetes supplies for people. So today I don't have just regular needles, but I've got a pen to practice with. Have you guys ever seen the insulin pens before? No?
I mean, my dad's something one that he took in his stomach. Like, push something or whatever your load.
Okay.
They gave him like the exact dose he needed or something. I
Okay.
know he kept it in the fridge too, but
So this is an insulin pen. It looks like a pen. And then you'll take the top off, and there's all your medication in there. Okay? So let's run through the motions of actually doing this. So I have my patient here. What I'm going to do is I'm going to, before I touch a patient, I need to always wash my hands, put on gloves. Okay, so I'm putting on gloves, wash my hands. I'm going to check my patient's blood sugar, just like the little guy did in the video there. And his blood sugar was, I don't know, 246. And his regimen calls for, if it's that high, to give about 6 units. So I'm going to clean the area with an alcohol pad. Now, I'm not going to blow on this person's arm or stomach that I am cleaning. I am not going to fan it. I'm not going to do any of that crazy stuff, because what that does is that is putting germs right back on the place we cleaned off. So then I'm going to take my pen. So I've done everything I need to do for my patient before I give him insulin, okay? I'm going to take my pen. I'm going to open me up another alcohol pad. And I'm going to clean the top of the pen off like this. You see it, Tracy? Okay. Clean the pen. Okay,
Yep.
so it's clean. Now I've got my needle here. There's a little backing on it. I'm just going to peel it off. So they look like this. They'll be in a little cap. And if you look down in here, which I don't know if you'll be able to see it on the camera, there is a needle down in there. So that needle is going to puncture the top of that. It's got a little rubber stopper there. So it's going to just go right down on it and puncture it and then screw it on. Okay. Then we'll pull this big cap off. We're going to lay it to the side because we need it. Now, our patient's skin looks dry. So I'm going to pull the little green cap off. Now, to prime this needle, we're going to do it to 2 clicks. 1, 2 clicks. Because this needle, when I stuck it in, there's a needle here and there's another end of it up here. It's actually got air in it. So prime the needle with 2 clicks and then you'll see it actually spray out. You won't be able to on the camera, I'm sure, because it's a small stream, but when you do this in person, you'll see it spray. And I've double checked my doctor's orders and what I need to give. So it's 6 units. So I dial it up. I just use my dial, Tracy, and dial it up to number 6 here on the pen. Okay, so this is my patient. Again, I'm going to leave it, let's see, I guess laying like this for demonstration purposes. Or maybe like this. Can you all see it still? Okay, we're going to go straight in. We're not going to go in like this. We're not going to go in like that or nothing wonky. I mean straight in. Just a 90 degree, okay? And the needle is very small, so it's going to go straight into the subcutaneous layer, the fat layer. So straight in, I'm going to push down on my pin top and then count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I'm going to pull straight back out. And then I'm going to ask the patient, you okay? And this time they're going to say, yeah, I'm doing just fine. I'm going to say, okay, thank you very much. I'm going to lay this cap on the countertop where I'm administering medications because we were taught earlier never bend, recap, or break needles, right? But we need to get this off of there. So we're going to, and this is, it's still not the safest method, but the scoop method. So what we're going to do is push this on like that. And then once it's covered, then we can push it on. And then that gives us the availability to unscrew this. Because this pin is going to be good for several more uses. So then we would put it back in the refrigerator or however that it says to store it. Most of them will go in the fridge, but if it's been used, I think they're good for like 21 days at room temperature. But that varies per manufacturer and per medication. So you always want to make sure of that. Any questions on that?
Hey, Dylan, where did you say to which part of their body?
It'll be in your packet handout, but most of the time it's going to be in their stomach, or it's going to be, in the back of the arms.
Okay, thank you.
And
Thank you, Gordon.
and then you can do on the front of the thighs. Now, you want to rotate those injection sites when you're giving these shots because it can cause a buildup of scar tissue. So you want to rotate them. So like if I give it in this arm at 12 o'clock, at 5 o'clock, I'd probably give it in this arm and then maybe switch back to this arm at 9:30. And then maybe the next day, maybe do it in the stomach over here, switch it back and forth and give things time to heal up.
Okay.
Any other questions?
And Dylan, one last question. A normal blood sugar level, what did you say that was?
I think the new standard is 90 to 120. Anything below 70 is hypoglycemic, and anything above that 120 mark is hyperglycemia. So that's
Okay.
the ranges right now.
Okay, thank you.
It used to be 90, like 80 to 100, but nobody ever stayed at 100. Society changed and we're eating a lot more unhealthier, so they changed it to 120.
Okay, thank you.
And then you can always, and then this cap just goes back on to that. Any other questions? Okay, so this is concluding our class for the day. I want to thank each and every one of you for being here and taking this class with me. I know it's a lot of information. I know it was a lot to take in, and I just want to appreciate you being patient and understanding and asking questions. The big rule is I want you to read everything. Read your labels, read your doctor's orders. I want you to know that if you're in doubt, don't do it. Ask for help, ask for more training. If you don't feel comfortable, reach out, ask for more training. Don't suffer in silence and be alone. Another thing is I do want you to realize that what we're doing here, I know we've had some fun in the class and Weird Al and all that is good things, but it's serious business. This is very serious. We are putting things into people's bodies that's changing their blood chemistry, and it's not anything that we want to mess around with. So I definitely want to say thanks again, and as always, have a blessed day and thank you.